Okay, some patient, fluoxetine, sertraline, they all works at the same level, but you need to know when are you going to choose which one. So when it comes to adolescent people or adolescents and the children's, we always go for fluoxetine. So regardless of other things, you can think of whatever it is, but fluoxetine is something that does not need to be tapered off. That's why has a long life and is the most commonly used in children and adolescent as its most evidence. Okay. So if they have given you any MCQs where their age factor is mentioned, the fluoxetine is the answer until unless they have mentioned something else. Okay. Then all SSRIs have a similar effectiveness. So don't say that fluoxetine works better than sertraline. They all works better, but it's just on the basis of half line. There are certain side effects. We prefer the other ones. Citalopram and escitalopram has a fewer drug interactions. So in older people, like 70, 80, who is taking calcium, vitamin D, amitriptyline, blah, 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 like other medications, in those cases, go for citalopram. Very simple. So you can think of older people, you can give citalopram. Sertraline is the safest in pregnancy and breastfeeding. So think of female, you can always choose this sertraline. Okay. I mean, we did not do beta HCG, but still this patient is a female and you feel like she's in a reproductive age. So go for sertraline. So now you know old people, citalopram, young people, fluoxetine, female, sertraline. Fluvoxamine is sedating and can be involved in many drug-to-drug interactions, so usually we don't go for that one. For OCD, aim for the maximum doses, sometimes higher. So I hope this makes a little bit of sense to you. When are you going to use which one? Paroxetine is something we use at the night time because it helps with the sleep. It says it helps with the sleep, but there is no evidence of that. SNRI is basically what are those ones? Venlafaxine, duloxetine, and one of the very good painkillers. We always forget about this one. Even I did not notice this line until I start working. That it helps with the neuropathic pain. Some people coming with the back pain, shoulder pain, joint pain. You can always option them with the duloxetine, and it really works like wonders. Okay. Although if you go 30 dose or 60 dose, it does not matter. They both works at the same efficacy. But for some people, you have to start with 30 and go to 60. I mean, I'm just giving you an idea to remember how to memorize it. Otherwise, 30, 60, you don't need to remember. But think of venlafaxine and duloxetine works really wonders for neuropathic pain. And then it goes for depression and anxiety. Let's suppose if a patient is coming for depression and for pain. In those cases, you can do venlafaxine or duloxetine. They cover both of the thing, and you can always educate the patient about that. Then comes the bupropion. Usually people do some Google and they do like to start their own medications for depression. There is very that kind of community too. So in those cases, useful for depression, seasonal depression. So when it comes to like people around December, January, having seasonal depression, so they usually like to go for bupropion. So think of people who comes in December or some specific time. Oh, I used to feel like that in the same time in the last year too, and I'm not sure which medicine doctor gave me. I want to start the same medication. So this is basically bupropion. And then not recommended for anxiety because of the stimulating effect. So it's best to not give in the anxiety time. So causes the less sexual side dysfunction. Do people, a lot of people, why prefer fluoxetine and sertraline, sorry, bupropion over those SSRI, SNRI because of the sexual dysfunction. They think bupropion causes less sexual dysfunction. I mean, it does not have to do with anything else, but like people do Google and they do prefer this one over that one. But increased risk of seizures and eating disorders, you have to be very cautious in that one. And they do causes less weight gain and sedation as well. So think of this one. If someone is concerned about weight gain, you can always start with bupropion. And there is people who is concerned when they start antipsychotics and antidepressant, they do like to ask about the weight gain. So they do like to ask in the MCQs as well. Like, do you know which medicine can cause weight gain and which one is good for weight? Even when you are talking about OCPs, oral contraceptive, you need to know which one, or the weight gain, how you are going to counsel that part, or it's one of the side effects that you have to mention. Then contraindication with a history of when are you going to, when bupropion is not given, if they don't have seizures, like people who came to you be like, oh, I want to start, I have read through Google about bupropion and now I wanted to start. So in those cases, you have to ask, but do you have any history of stroke, brain tumor, brain surgery, close history of surgery, seizures, any eating disorder? In those cases, you are not going to give bupropion. Then TCS amitriptyline, but it causes a lot of sleep. So older people usually don't like to go for this one. But at the same time, I said it helps with the pain as well. So people go for amitriptyline, and I mean a lot of old people are taking it. So it's a very common drug to do abuse or misuse. So that's why you have to be very cautious with amitriptyline. So it's used for OCD and then causes ECG changes, highly lethal in overdose. Then the nortriptyline, it's not that commonly used, but still you have to look for the ECG. Then comes the phenelzine, which is monoamine oxidase inhibitors. In this one, atypical anxiety, and then it's basically, you need to know this one, requires strict adherence to the monoamine oxidase diet. Which diet? The cheese one. That is something that you have to look for. Then Rimad, which is moclobemide, which is basically for the social phobias. Then mirtazapine, it's very commonly used. It's for agitation, insomnia, or cachexia, somebody who stop eating. Then the SPARI is basically vilazodone. So usually they just recently added it. Usually used for the patient in those with constipation, but diarrhea is a common side effect. Then the vortioxetine, and then improves the body. So you need to remember mainly SSRIs, SNRIs, then comes the bupropion, amitriptyline. Now you have extra mind or you've extra brain to memorize extra things, then you can go for the other things. Like you have extra capacity, you can, digest more things, then you can go for other things too. But let's suppose if you want to keep like the important one, at least do these ones. Especially comes to bupropion, they do like to check. Then here is the one, monooxidase inhibitors. What are those ones? And what are this one, the name of them. Okay. Then when it comes to this one, you have to remember the time. This is one of the most important time because a lot of people after using it for 1 or 2 weeks, they come back, be like, oh, medicine is not working. I want to change it. So in that case, you have to tell them it takes 2 to 4 weeks. Or when you're going to start a medication, what are you counsel the patient? This is something that you have to counsel them when you're starting the medication. If it's working, then go for continue medication for 6 to 8 weeks, then symptom remission, then you can look for reoccurrence and continue the medication for 2 years. But if it's not working, then change, switch, like go for second line, third line. Usually a lot of people do work good with sertraline, fluoxetine, hardly someone switch to the next level. So you can always just switch from one SSRI to different SSRI or from SSRI to SNRI. Usually we go from SSRIs to SNRI when they start having side effects with SSRI. Otherwise, if it's not working, then switch from sertraline to same class escitalopram, citalopram. They usually works really good for some people. Okay. So it's not like hard and fast rule. You have to stick with fluoxetine. Then you can read from the side which one are the serotonin receptor stimulants and then how does it work. So optimization is how you like this is sometimes like I don't know, it's QE1 point of view, it's important. This optimization, augmentation, combination, and switch. Because they can give you, oh, this was drug, now this is being used. What is this process? So if you don't know this is an augmentation, or this was a combination, or this was a switch. So optimization is when you increase or decrease the dose. Augmentation is when you add one more to help the previous one. Then combination is using two drugs together, like especially there is some formulas which contain both of the regime together. Then comes the switch one, then moving from one to another. It is important to fully treat the difference. So it's important to have an idea about what is which one. Symptoms of antidepressant discontinuation is basically flu-like symptoms, insomnia is like finish, nausea. So usually they have GI symptoms. Then serotonin syndromes, as we already discussed, they have GI symptoms, redness, and then rigidity or twitchiness, myoclonus is there. Treatment is discontinuing the medication, simple. Discontinuation syndrome is basically when you stop taking antidepressant, most commonly with the fluoxetine. That's why it's very less likely using paroxetine. In my practice, I think we are hardly giving it to one or two people who actually want the paroxetine. Otherwise, we don't go for that one. And then venlafaxine, which because they have short half lives. Symptoms usually begin in 1 to 3 days when they stop using it. So that's why then you have to restart the medication again. As you can see from here, SSRIs, SNRIs, TCA. If you don't want to remember from that table, you can come here and then read this one from here. SSRIs, which one are those one? SNRI, TCA, and monomines are NDRIs, bupropion, Brema is meclobamide, NASA is this one, this one. Then comes the side effects. How do you remember the side effects? Since we already discussed the main important ones, then SSRI, you have to know it causes tremors, insomnia, headache. So starting from top, head to toe. Starting from the top, what does it cause? As we already discussed, this one, serotonin syndrome. So it will can give you an idea how can it cause like a tremors, rigidity, nausea, vomiting. It's one of the most common is nausea, having GI symptoms. Then weight gain is one of the most common, as we already discussed that bupropion is one of the good one for weight gain. So then which one is not good? This one, SSRI is one. Then one of the most important causes is sexual dysfunction. That's why people likes to go for the bupropion. It has less sexual dysfunction and all. Then increase heart rate, OTC, serotonin syndrome is there, decrease platelet aggregation, and all that. So mainly you need to remember the main concepts about serotonin syndrome. Wherever the serotonin, SSRI, SNRI is usually the side effects are kind of same. Even if you go into this one, SNRI, it's mainly the same. Similar to SSRIs because they have serotonin. Serotonin works the same, like GI symptoms is same, CNS symptoms is same, like rigidity, tremors, insomnia, restlessness, and then GI symptoms are there, then leading towards, because how you can think of this one, orthostatic hypertension, because if they are having diarrhea, then lead towards the orthostatic hypertension. And we already know when it comes to dehydrations, in the start, the BP is high, then it gets to low. So this one, and yeah, so SSRI, think of the problem with the sexual. They do present with the sexually and weight gain. These are two most common side effects with SSRIs. And people do like to think about something as compared to SSRIs to switch to something else. Then come the tryptyline. It's mainly something, the falls are very, very common with the amitriptyline, with the TCA. That's why it's very less likely to use in older people. But yeah, some people do take it for pain as well. Then phenelzine, usually you need to remember the tyramine one. What are the foods that you have to avoid? Basically, the cheese, wine, that one can causes the hypertensive crisis. So this one. Then comes the bupropion. We already know it causes the weight gain. So you need to know which were the contraindications for bupropion. So in those cases, you can see. So it can causes dry mouth, nausea, vomiting, decreased appetite, seizures threshold. So usually they do like to ask about the seizures, tremors, anxiety, and all that. Then if you can remember the rest of the thing, you can go for it. Usually they are kind of same. Okay, so risk in overdose, what can they cause? Tremors and then seizures seen in overdose. So usually the overdose of TCA is something very, very, very important. You can, I mean, when it comes to side effects, SSRIs are important. When it comes to contraindication, bupropion is important. When it comes to TC overdose, TC is important. So what happened in that overdose? Toxic in overdose, 3 times therapeutic. So presentation is anticholinergic effect, CNS, depression, and seizures. So in the long cases, it can cause the heart, and then treatment is activated charcoal. So we already discussed this in toxicology as well. So giving the IV diazepam for seizures, physostigmine, do not give IPAC, can cause rapid neuropathic. Then the drug interaction is basically the cheese. We already monoamine oxidase inhibitors ones. Then comes the mood stabilizers. In this one, come to this table directly. Now, what do you need to remember in this one? Lithium. You need to remember everything about lithium. Because lithium is sometimes not everything, like I would suggest at least remember at least from here. So what do you need to remember is basically monitoring levels every 5 to 7 days until therapeutic. Once you figure out, like every week, and once you figure out that everything is okay. It's monitor the thyroid function, and creatinine is very, very important. Okay. Now comes to here. So in this one, you need to remember the side effects of lithium on your fingertips. On your fingertips. Like if someone asks you anything, I mean, I would suggest, like even if someone asks you any side effects you don't remember, it's acceptable. But when it comes to lithium, you need to know each and every single word of this one, at least from here to here. Okay, so it can causes nausea, vomiting, stomach pain, polyuria, polydipsia, neuropathic, and diabetes insipidus. This word, glomerulonephritis, renal failure, glomerular filtration rate, fine tremors. This word, headache, fatigue, lethargy, reversible benign leukocytosis. This word, then abstinence anomaly. This word, hypothyroidism. This word, weight gain. This word, edema, worsening of psoriasis, bradycardia, ECG changes. And then its interaction is one of the most favorite MCQs. NSAIDs, thiazide, ACE inhibitors, metronidazole decreases the clearance risk for the lithium toxicity. So if someone is taking that medicine, lithium toxicity can happen and they can give you a scenario. Then comes the lamotrigine. It's basically causes the skin problems, suicidality when initially treatment. So skin rash is there. Which one? Steven Johnson, and causes nausea, vomiting, and then ataxia, dizziness, diplopia, headache. Then comes the Develprox, which is basically the Epival. In this one, usually it causes the liver dysfunction. Most important is liver dysfunction. Then it can also affect your skin, hair loss, weight gain, GI functions is also there, and neurotube defects usually in pregnancy. Then comes the carbamazepine. What kind of it causes this one, agranulocytosis. Leukopenia, agranulocytosis, aplastic, and then ataxia, drowsiness could be there, nausea, vomiting, neurotube defects. Okay. And usually they interact with OCPs, both both Develprox and the carbamazepine both interact with the OCPs. As you can see, the lithium toxicity in this one, it's important, and it is the management discontinue lithium right away. Then lithium level has fallen down, IV saline, and the most important is hemodialysis if lithium is more than 2 millimole. Long-term lithium can be used to be a neuropathic and diabetic insipidus is the most common patients. Then you can read the anxiolytics is basically the benzodiazepines. When you give the benzodiazepines, patients start feeling drowsy, calm. It's mainly used for the seizures. So in those patients, it's like a CNS depressant. And which ones are the impaired liver function that are safe? Lorazepam, oxazepam, and dimaxepam. So usually we go for lorazepam. Then the side effects is CNS, dependence, tolerance, and withdrawal. Withdrawal is basically when you stop taking it, person get less. So hyperpyrexia, seizures, death is there. So in this management, taper slowly, may need to switch to a long-acting benzodiazepine. So someone who's taking diazepam, you have to go for lorazepam. Then the overdose is basically someone who is taking it for the long term, so you have to stop it and maybe admit that patient. Then buspirone is basically used for generalized anxiety disorder. And Z drugs, what are those Z drugs? Zopiclone, Zolpidem, those ones, Esopilon. These ones are the one. And it helps with the sleep. Simple. And usually doctors is very reluctant to start any Z drugs. Patient get dependent on this one. So you can see which one is causes the help with the alcohol withdrawal and all that. You can just read from here. Okay. Then the electrocompulsive therapy in this one, what is important is basically what are the side effects of it. So risk of anesthesia, so you can read this line. Risk of anesthesia, memory loss, which is basically retrograde or anterograde, both of them, tends to resolve by 6 to 9 months. Permanent impairment could be there, transient headaches and transient myalgias. And then it's very safe in pregnancy. I don't know how it works, but it says it's very safe in pregnancy. And then because usually its response is rapid, so people like to prefer this one, especially when it comes to pregnancy, high suicide rates, and like frail elderly people who are thinking of getting, made. So in those people usually go for ECTs, and it's very common and safe. So this one. ECT in society is basically used in mental illness. Then RTMS, transcranial magnetic stimulation. It's usually for people who are hopeless or depressed or don't want to do or lack of motivation. So, people who are PTSD, eating disorder, so they give stimulation with the transcranial magnetic. It's not that effectively like we do practice in our practice, but it's something the psychiatrists used to like. Then magnetic seizure disorder is also used for the depression as well as anxiety. Neurosurgical treatment is basically, if you want to read, then just remember the name: ablative lesions, deep brain stimulation, and vagus nerve stimulation. Then other therapies is phototherapy, aerobic exercises, one of the very good for PTSD, motivational, schizophrenia, help with the running, and it's very common with the cannabinoids like marijuana. So those people's, because marijuana people have a motivational syndrome, we just read today. So you need to remember that. Okay. Then you just need to remember the form 1 and then form 30. Simple. You just need to remember the name. That's it. Okay. So that's about it with the psychiatry. If you guys have any question, you can ask me. And if you wanna go, what next topic you guys wanna cover, I'll go with that.
Bupropion cause side effect is sedation or insomnia.
Sorry, which one?
Bupropion